Hi, and welcome back to Becca Babbles podcast. I'm your host, Becca. I'm a certified personal trainer, holistic health coach, and future chiropractor on my way to figuring out this thing we call life. Now, let's get babbling. Hi, everyone, and welcome back to Becca Babbles podcast. This week, I have a special guest that is going to join me today. It is Dr. Ericka Mennerick. I love Erika. She is such a light in the world of chiropractic. She is actually one of my instructors for NPI, the club that I am a part of at school that I had the honor of being president for a few trimesters. I met Erika through the Motion Palpation Institute, since she is one of the instructors, and I actually went to one of her seminars, her pregnancy and pediatrics seminar, and I had so much fun learning from her. I was like, I have to have you on the show. And she thankfully said yes. And so today I am bringing you an episode with her where we talk about everything from pregnancy to babies to we dive deep into DNS, dynamic neuromuscular stabilization. If you have heard of that before, that is a technique that I like to use with my patients, and me and Erika get a little nerdy about a specific baby that came into the student clinic, and I got to pick her brain on that. So if that's something that you're interested in listening to, definitely hone in on that conversation. But we also break it down if you are not accustomed to DNS, we break that down and explain exactly what that is and why it's important. We also get into postpartum, which I think is a topic that not enough people talk about, the importance of preparing for pregnancy to help in the postpartum, but then also like what to do in postpartum and what to expect and the struggles that you may be going through. And Erika breaks down how she helps her patients who are going through postpartum. So this is a jam-packed episode with information that you will need to listen to over and over and over again. But so that you know a little bit about Erika before we get into the episode, Erika is a chiropractic physician for more than 20 years, where she has been treating patients of all age at Trillium Health and Wellness in Illinois. She is an instructor for Motion Palpation that are hands-on seminars worldwide helping chiropractors get better at adjusting and rehab, and she has a special emphasis on pregnancy, postpartum, and pediatric care. She also teaches pediatric adjusting and other topics, a part of the chiropractic diplomate for the American Chiropractic Association, and she lives with her partner Tom and her 2 college-age children. She spends her free time hiking, volunteering, and just love being in nature. So she is such a sweetheart in this chiropractic community, and I hope you learn lots from her today. But with all that being said, I can't wait to babble with you next time. Hi, everyone, and welcome back to Becca Babbles podcast. I have a special guest with me today, Dr. Ericka Mennerick. Would you like to say hi?
Hi, nice to see everyone.
Yeah, Dr. Ericka Mennerick, I'm extremely excited to have you on because we're going to talk all things pregnancy, babies, and postpartum. I haven't actually been able to talk about this topic on the podcast yet. With that being said, I know pregnancy is something that like most women go through and is really misunderstood by most of the population. But I'm really curious, what first made you passionate about working with pregnant mamas and babies?
My own experience, quite honestly. I wasn't overly interested in pregnancy care until I myself got pregnant when I was in 9th try of chiropractic school. Surprise! My husband and I at the time, he was working full time and I was in chiropractic school, and we weren't particularly trying, but obviously we're not trying hard enough. So it was definitely a surprise for me, and that kind of launched my journey of like trying to figure out how chiropractic care fit with pregnancy and pediatrics, and what I could do. I think some of it too was like watching my classmates just be overly fearful of like, I'm not a tiny person. And so like people were we adjusted each other a lot. And then I got pregnant. I'm like, hey, can you adjust me? And people were like, I'm like, you're not going to break me. It's good. Like they're suspended in water. It's all okay, you know? So I think just trying to figure out, like, realizing how uncomfortable students were with adjusting pregnant patients, and really then trying to say, okay, well, what do we know about pregnancy and chiropractic care? And how can we make this easier? Or are there things that we have to watch out for? And if so, what are they? And so really, I mean, honestly, my start into it was my own personal journey of just trying to figure out what worked and what was okay and what wasn't, and go from there. So yeah.
Yeah, a lot of trial and error. What was like one of those eye-opening moments where you're like, "Oh, I didn't know this about like pregnancy."
Oh gosh. I have big kids now. You know, Cole is 21 and Kira is 18. So we're talking 20 years ago now, you know, trying to recall like what I didn't know anything. I joke to, you know, I ended up having home births. And I remember sitting in school and having our pregnancy class, maybe even just in like emergency care, and talking about home birth and talking about, you know, other things regarding you know, health and pediatrics and such. I remember thinking, I'm not going to be one of those wackadoos that has a home birth and whatever. And then fast forward, I had a very dear friend of mine, Judy. She's still a dear friend of mine. I went on a walk with her this week, and she has 3 kids. The first one was born in a hospital with a midwife. The second one was at home with a midwife. And then the third one was at home with a midwife and a water birth. And it was talking with her, and I was there the day her third one was born, not like as part of the labor and delivery by any means, but like afterwards. I brought her and her husband and her kids dinner. And she's like, come on in here, talk to me. And I was like, but you're like in your bed with your newborn. She's like, I'm fine. And then here, and then like dumped the newborn in my lap. And I was like, okay, I got this, you know? And so I think honestly, like that side of it, she was really my inspiration to be like, oh, maybe I can do this. Like other people do this thing. And realizing, you know, trying to shift my own mind from like now knowing I didn't want to have a ton of interventions in my birth if I didn't have to. And so also like knowing my body and understanding how it worked from my experience in chiropractic school, and just feeling like if I could trust my body, if I could let my body do what it's hardwired to do in many ways, like this is possible. And you don't have to, the idea of home birth came down to, I don't want to have to fight a system that's set up for interventions in order to have a birth without or with as little as possible interventions. And so that's where kind of my choice to do home birth was from. I love the water. You know, I did a lot of reading about, you know, benefits of water birth, cautions over water birth. Like people think, oh, but their head's under the water when they come out. It's like, well, yeah, but they're still attached to the placenta. You know, they're still getting oxygen from the mother. And there's some interesting stuff that shows that if like they didn't even take a breath until they hit the surface, like until they hit the air. And there's parameters around that. And I found midwives who were really experienced in those types of things. So I think that's really long answer to your question, but I mean, that's kind of how my pathway down the more natural, I guess, healthcare side of pregnancy and birth came to be. It was a friend who inspired me and kind of showed me that no, this is possible, and it might be a really good choice. So
No, that's awesome. I feel like I've even thought about like what in the future, like when I have kids, it's like, do I want to do like hospital birth or do I want to do like a water birth? But then it's like, I don't know a ton of people who do water births. And that's really interesting where you had said the like with the placenta, like they're still getting oxygen there. Like I didn't even know that. So there's a lot of things that like people don't know. Could you go more into depth into like what you learned about water births and like the benefits of doing that?
yeah, for sure. There's, like I said, there's some parameters around it. So you want the water to be within a certain amount of your own body temperature. And the midwives are really good about watching that and keeping an eye on that and adjusting if needed, because you're in labor and like you don't really have a frontal lobe at that point. It's very primitive brain. And so that's, you know, that I'm more relaxed in water. When we think about birth as a human process. Like birth itself is a parasympathetic process. So we talk about the sympathetic nervous system, that's your fight or flight. Parasympathetic is rest and digest. So the more relaxed and calm and at peace you can be and not worried about other things going on around you, the more that your body is going to be able to have a physiologic birth. And so, I was comfortable in water. I knew that I could be more relaxed in water. And then you start reading about things like the water helps to soften the perineum. So there's less of a risk of perineal tears when with water births. There's an argument that's an easier transition for baby because they're going from the warmth of the amniotic fluid to the warmth of the birth pool to then, coming up to air. They're still connected, like I said, to the placenta. So the placenta continues to give them oxygen for about 5 minutes after birth. Like there's still blood flow coming through the umbilical cord if you don't clamp it right away. We brought the baby up and put him on my chest, and I have this wonderful memory of my husband being over the back of over my shoulder, and he goes, "Well, it's a boy." And Cole, laying on my chest, Cole like whips his head around and looks at him like, "Oh my God, I recognize that voice." Like it was one of the coolest things, like from Skip having talked to him, when he was in utero. So I think for us, like, knowing that we had that possibility to really be just with our family, just us and our midwife and her assistant. That's all the people that we had there. I think it fit for us and it felt right for us. A lot of people worry about, what about a complication and, oh, if this happened or that happened. The midwives are really good at detecting those things early. And if there is some sign of distress, either for mom or for baby, like getting you to the hospital quickly. We lived within 10 minutes of an ER. So it wasn't like we were way out in the country. We knew that there was, emergency medical within a short period of time. So that was a factor. And then just more and more, the research that has been done even since then has shown repeatedly that for uncomplicated pregnancies, you're as safe, if not safer, having a home birth than you are a hospital birth. And that's because of every time you add an intervention, you add risk. So in the hospital, they talk a little bit about like the cascade of interventions that one thing leads to another thing, leads to another thing. And you can end up, kind of going down this path where you didn't really want to go. So kind of taking some of those things away and really preparing ourselves too, to be at home. We did some childbirth classes to prepare for labor, and then the midwives they carry Pitocin so that they can use, we wouldn't use it to like induce labor, but Pitocin can be used after birth to stop hemorrhage. They typically carry oxygen. They carry things like with my second birth, my midwife checked my hemoglobin with a finger prick because I had lost some blood with that one. She started an IV in my bed. Like they carry this equipment with them so that they can do basic stuff. But they have some of those abilities, and then they know how to transport when needed. So I think those were some of the biggest things I learned as I was going through it, and learning about water birth in particular, not just about water birth, but about home birth. The water was just a bonus. It's comfortable. So that's my
because you're a big swimmer, right? Like you enjoy swimming and all the things like that. Yeah, I enjoy
swimming. Yeah, I never swam competitively, but I lifeguarded, and we just were I'd kayak, and we're just kind of water people. And I've always been really, really. I'd scuba dive. Like I'm just somebody who's drawn to water. So yeah.
No, that's awesome. I think that's the biggest thing, is that just like making sure, like, if this is an opportunity that someone wants to do, to make them realize that like this is possible, and like if you feel safe doing this, and like if you prepare, like you can do this. When you were picking a midwife, like what were some non-negotiables for you that are important?
That's a good question. The situation here in Illinois is different now than it was back then. Now we have licensure for certified professional midwives. And so with my first pregnancy, I started with, we have certified professional midwives who are trained in home birth, and then certified nurse midwives who are more trained in hospital birth, but from a more holistic perspective is the best way I can put it. At the time, only certified nurse midwives were licensed. And I started with a certified nurse midwife in Lombard, which is actually, she's right by the chiropractic school where I was going at the time. And she was great. I had good care there, but then we got to talking more about, well, if there was an emergency, where would we go? If it wasn't emergency, where would we go? And her at that time, the certified nurse midwives had to have what they called a collaborative agreement with an OBGYN. Well, the doc that she collaborated with was in Maywood, which was like if there was traffic, it could be an hour and a half, hour and 45-minute drive away from my house. And the more I got to thinking about it, like if it was a non-emergent, like if it was an emergency, we go to the emergency room, the closest emergency room. But if it was a non-emergent type of thing, I just pictured myself like in the car, uncomfortable, in labor, and being stuck in traffic driving into the city. And I was like, I'm just not comfortable with this. And so actually at 28 weeks, I switched midwives with my first pregnancy. And I happened upon just a support group, home birth support group, and was able to go and talk to some midwives there, and ended up switching to one of the midwives I met there. So non-negotiables, I don't know, wanting to know, I ask things about like, what do you carry in terms of emergency equipment and things like that. I asked them, can you tell me about a time where you had to transport and how you handled it? How long have you been doing it? Like how many, and midwives are great. They call them catches. They don't call them births. They say the birthing parent, like they're the ones during the birth and they're just there to catch and make sure everything's okay. So how many catches do you have? How were you trained? And some of it's just a vibe, some of it's, do you mesh with this person? References, things like that. So I don't know that I had a non-negotiable. I wanted somebody obviously who was well trained and who had been through the ringer a bit, So,
Or like,
and
what are
most of
some
them
things?
have. Most of them have. They've done an internship under other midwives, and they've been to a number of births before they're ever sent off on their own. Most of them will have an assistant with them. They'll have a friend or colleague as backup too that they can call and talk to. So it's like us, they have a support system too.
Yeah, no, that's really important. Yeah, I was just curious, like, if, like, what do you recommend to, like, patients when they're, like, looking for a midwife? If there is something that you're like, oh, I like this one, or, like, maybe you should, like, ask them these questions, which I think knowing all those things that you had mentioned are important.
Yeah. Yeah. And at this point now, I've been around here long enough that I know most of the midwives in the area. Personally, like I know them pretty well, and I feel comfortable being able to say, hey, you should talk to this person and this person, like here's your options, and go from there. So part of it's knowing your community.
No, that's for sure. So I want to dive a little bit more into like pregnancy and like when you're starting to get pregnant, like how does the body change, and like how do the ways that like we need to stabilize start to change that people may not be aware of? She smiles so big.
The thing that came to mind, like, how does your body change? Well, the first thing for me was I had terrible, terrible breast tenderness. So being a doc in school, I guess it was 7th try when I got pregnant. It was 9th try when I had him. So I learned very quickly that I could not do supine thoracic adjustments just due to the pressure that I had to put on the patient on my own chest. It was like, okay, we're done with this for a while. Like, I cannot manage. So, your own body, like as a doc, when you're practicing too, like you gotta work around some stuff. And then obviously as my belly got bigger, had to give up sideline drops because we kind of, the way we do it with motion palpation, we kind of end up impacting our belly on the hip. So you don't want to be impacting your belly, period. So switched to doing kicks this is one of those where whenever I teach this stuff too, I tell people, like, you never know when you're going to have an injury or something where you need to know both. You need to know how to drop, you need to know how to kick. And then when it got really late in pregnancy, having the pelvic drop piece on my table, so that if it just wasn't feasible, my size versus the patient size, like being able to at least do some mobilizations and things with the drop piece on the table. So, I kind of freaked out when I found out I was pregnant. I was like, how am I going to finish school? How's this going to work? And it really did work out very well. So with being in school, if there really was something that a patient needed that I couldn't do, I could go grab somebody else from down the hall to say, hey, could you come sideline this person, or whatever the case might be. So it's a little different when you're out in practice and you're on your own. You're like, buckle up, we're going to do this. So Cole came 3 days after his due date, and he was just after Thanksgiving. And I worked up to the day before. I was in my internship, but I was clinic until the day before I had him. In fact, I remember waking up and calling my clinician and being like, I don't know, I kind of feel weird this morning. I'm just gonna stay home and make sure this isn't labor. And I was like, man, I'm really gassy, and I don't know. And my husband was like, yeah, your gas is coming like every 5 minutes. He's like, that's contractions. I'm like, nah, I don't think so. I just feel a little weird. And yeah, no, I was totally labor. So he called it before I did. Yeah. So
what are some things that you find that like patients end up dealing with that they're like, oh, I feel a lot different, and like, how do you work through that?
Yeah, I think the hardest thing that I try to get through to patients, and this is the crux of it, is that the more I can get them to rehab early in pregnancy, the better later pregnancy is going to feel. And it's such a struggle because sometimes they don't feel great, like the nausea and the fatigue that you get in the first trimester of pregnancy can be a real struggle to be like, I just need some side bridges and some squats. Like, can you give me these two things? Like, if we can do these two things and like get some strength in your obliques and your deeper low back muscles and your glutes, like, please, like, if we can get some strength here, you're going to be so much more comfortable later on in pregnancy. And I think that's the hardest thing, is they don't feel great, so they put it off. And then next thing you know, it's like they're into second trimester. Now it's starting to hurt more. Now they don't want to move as much. And then you get to third trimester and they're really uncomfortable. And we're kind of behind trying to get them, more comfortable again. Now, it's not always that case. I've certainly had patients who come to me and say, hey, we're thinking about getting pregnant in the next 6 months. And what can I do to help get my body ready? Like that. I love those patients. Like, because I'm like, yay.
We can prepare.
We can prepare. You're going to have a great pregnancy. So I love those patients due to the fact that I can get them doing those things, and I can even just getting them out, if they're not exercising regularly, getting them out walking, but definitely adding some core stability stuff, however you want to do that, dead bugs, DNS, side planks, Pallows press, I don't care. Like, we just need to challenge the core, improve stability, glute max, glute med, even foot and ankle stuff, just because we get changes in the laxity of the feet. So making sure they've got good foot biomechanics, make sure that, maybe put them on a toe pro from human locomotion and Tommy showed stuff. Like we can kind of go down, do an assessment and figure out where those Texas size lesions are, of where are the weakest points in this patient. Where are the things that are going to be most likely to break down as we add load, whether that's weight, whether that's instability, positions, if we can clean up some of those biomechanical, deficiencies before we start adding weight and instability to it, they're going to have a lot easier time late in pregnancy.
Yeah. I've been loving on social media, and maybe it might just be my own algorithm, but seeing the no, we need to exercise. We need to exercise before pregnancy and during pregnancy. Yeah. None of this bed rest stuff.
Yes. And that attitude is shifting even now from 20 years ago. I mean, they're moving more and more even towards we don't have to avoid all abdominal exercises. There is some benefit in not letting yourself completely atrophy in the abdominal muscles throughout pregnancy. So even that is kind of eye-opening, and it's a little scary to be like, all right, for years we told you no sit-ups, crunches, nothing that's going to stress like rectus abdominis, and that consensus is beginning to change. We're beginning to look at that differently, especially in active people who had tone in those muscles, who had a lot of strength and coordination already. It's actually okay to let them work some of those during pregnancy so that they aren't so atrophied when they get out. So yeah, it's been a big shift going all the way from like, you're right, bed rest and don't do it, you're fragile, and to now like, yeah, like have some limitations on just making sure you're not getting lightheaded, making sure you're eating if you're going to be working out, making sure you're hydrated, making sure you're not getting too hot. Like the heat is a big one for a lot of women I find in pregnancy. Like if we can just keep them a little bit cooler, they're going to be able to do more work in the gym and be able to continue. So
yeah,
I think it's a smattering of things. Yeah.
I think it's like people's ability to like listen to their body. Now that I'm like in clinic and actually working with patients, realizing how many people aren't in tune with their body is really interesting.
Oh, yeah.
Yeah. Yeah. And so like when you're working with a patient and maybe they're like really scared to do those core exercises, like what are you recommending them to do? What are you saying to that patient to kind of just like ease them and be like, hey, it's okay?
Yeah, if they're really fearful of that, then I would stay away from something that's like a midline or sagittal plane type movement. I would try to go more frontal plane. So side bridges, you could do like a dead bug, but keep the feet down. Just lift the feet, lift the arm, or extend the arm, lift the knee, but keep the other foot on the ground. And again, that's where things like Pallof presses or like a cable pull down, where you're working like a diagonal pattern, maybe in a standing or in a half kneeling position, where you're still getting some stability work in there, but it doesn't feel like an ab exercise, so you can sneak around it.
Yeah. You're like, oh, we're just moving your arms. Yeah.
We're just gonna do it this way, put them on an uneven surface. I mean, those are probably the biggest things I would look at. But if they are nervous about it, like, and that's the thing too, like if they're doing one of those moves and they're like, I'm getting a lot of pulling, and okay, don't do it then. You're exactly right. Like if it's uncomfortable, like we're going to switch the exercise. Just like if I'm working with a patient with knee osteoarthritis and I'm trying to strengthen quads or something, like if they tell me a lunge hurts, well, okay, let's do something modified. Let's give you a TRX and give you some support. Let's switch to I don't know, it's something else. Let's do an RDL instead or something. So I think it's just and this is okay, this is an aside, but like this to me is like the fun creative side of being in practice too. And it's funny, my daughter's a freshman in college and she's in a nursing program. So she's in like the thick of anatomy and physiology, and she's like, I like this so much because there's a right answer and there's a wrong answer. And I said, oh honey, my sweet summer child. Like, yeah, that's like that now. And then you get into practice and there's a whole lot of like, well, this will work, but this could also work. But if you don't like that, we could do this too. And I love that creative side. And I didn't expect that in practice. And it's probably my favorite part of practicing. So anyway, I got a little off topic there. But yeah, if they don't want to do a straight up ab exercise, there's ways you can work the abs without doing abs.
Yeah, not everyone has to do crunches and oblique stuff.
Mm-hmm.
When you're looking at patients, do you ever focus on like what their breathing pattern is like and how does that impact their pregnancy?
Yes. Part of it too, it's interesting in pregnancy when we look at breathing patterns, as we know, so many people just hold so much tension in their abdominal muscles and suck the belly in, pull the belly button towards the spine, however you want to put it, that it's really hard for them at first to learn how to relax the belly. I mean, we find that in just our typical patients, let alone our pregnant patients, but teaching them how to relax the belly and breathe into the sides of the rib cage. Again, that's another one that if we can teach them to do that earlier on in pregnancy, they're going to have better breath control and breath support later on in pregnancy. Because at some point the belly's going to start to take up some of the diaphragm movement, but teaching them that 360-degree breathing And again, the low back or low rib cage breathing is going to help, both with stability as well as GERD, like the reflux that they get, the heartburn that they get. So many times if they're holding so much tension in the belly, like we're just pushing the stomach up into the diaphragm, and you're going to get more and more reflux. And again, because they're not getting the good abdominal diaphragmatic breath, you're not getting the closure of the sphincter. And so you're going to get more of that reflux. Now, the progesterone levels play into that because you've got some relaxation of smooth muscle. So that's a factor that we can't change. But one of the things I'll have patients do is sit like cross-legged with their hands on their low belly. I'm doing it, but you can't see it. But hands on the low belly, kind of cup on the low belly like this. And then I try to like prop them up against the wall, or have them sit on a cushion like up against their couch, but on the floor, and just say, okay, I want you to sit up nice and tall, but then close your eyes and think of letting your belly like fall into your lap. And so you teach that relaxation of the belly, of letting the belly release, letting it sort of fall against your thighs as the belly gets bigger, and then breathing into that space that's created. Because there's some, there was a study I read quite a few years ago now that talked about when we look at preeclampsia, one of the things that they think causes preeclampsia is actually increased abdominal pressure that causes a blood flow restriction. And so by being able to release the belly, release the abdominal muscles, and relax through that, so there isn't so much tension through there, may have an effect on that. I don't have a study on that, but it was an interesting paper I read about the intra-abdominal hypertension almost that's related to that. So yeah, breathing's huge. I originally there was like DNS was like, no, you can't really do much during pregnancy. And I think you definitely can. Like, it's not going to be perfect, but you certainly can help to retrain breathing and relaxation in that state. So, yeah.
Being in clinic now, sometimes when I'm like teaching breathing, patients can get really frustrated just because they're like, I can't do this. Or like, and so like, how do you approach a patient where they start getting frustrated with those types of exercises? Is it one of those things you just move on, or like,
no,
do you have
one of my mentors, a dear friend of mine who's since passed away, Dr. Humphreys, he used to teach neurology at National, and he had a joke that he'd say, unless you were a singer or a swimmer, the only instruction you ever had on breathing was a slap on the ass at birth. So it's no wonder so many of us do it wrong. No, sometimes change. So I make them laugh about it, and say, no, this is hard. This is different. You've been taught to suck your belly in. You thought a deep breath was this instead of, down low in the belly. It's okay. Like, there's lots of people who do it this way, and you can teach an old dog new tricks, and they usually laugh at that one too. So I don't take myself too seriously in practice, and so I think that's part of it too, is just trying to meet the patient where they're at. Physical feedback, showing them on myself, putting like a thumb and an index finger in my side and kind of in the crook of the QL, and say, like, look, see, you can see expansion between my thumb and my finger, 360 degrees, like start to give them those visuals of like, oh, you can do it that way. It's like they've never seen it before. So showing them, putting my hands on their body, having them put their hands on their body to feel where that's at. Telling them this isn't an exercise at first, this is a relaxation. Because I think a lot of patients, they say, we're going to do an we're going to teach you how to breathe. And they're like, I will breathe, right? It's like, no. We're looking for efficiency here. Show me how little effort you can put into this and still accomplish what I'm asking for. And so I think it's flipping the script on that too, and just being like, no, less is more. We need less. As little effort as possible is what I want for you. And they're like, what? But I do everything really hard. I'm like, I know, that's why you're here. So that's part of it, is kind of flipping the script on what are we doing here. Sometimes it's a position change. Sometimes, if I've got somebody who comes from a yoga background, like doing breathing exercises in seated is often easier for them than doing it supine. for other people, it's not. I'll typically start people in like a supine 90-90 position. So as flat as they can, neutral neck, and then feet up on the ball with the hips at 90 degrees. So that's where I start. And if I'm not getting it there, then we might try shifting positions. But usually within 10 minutes, I can usually get them to start to feel what we're looking for, and then try to just send them home to practice it. So I just say, play with it. Like, this is going to take a while to retrain. It's okay. Just keep trying.
I think, like you had mentioned, like, don't take yourself too seriously in your practice, because like patients want to have fun and they're going to get frustrated if the environment is like, you need to do this task.
Yeah, and worried too. They come in most of the time because they're worried about something. So, especially too, like when you have a few years under your belt and be like, this isn't new. I've seen this before. Like, you're not normal, but you're pretty typical.
Yeah.
This is a really common thing. It's I understand why you think that, or why your body's trying to do it this way, or just teaching them too, like if they have a lot of tension, talking about how their brain is trying to protect them and they're using this tension to guard something, and that's okay. But now we want to start to teach the brain and the body a different way to do it, so that you don't have to hold so much tension. So I think always like kind of letting them save face, but also honoring what it is their body's been doing for them under the circumstances. And we're just trying to change those circumstances. So not making something right or wrong, but just honoring that this is what your body's doing for you. And we're just going to try a different strategy now.
Yeah. No, I think the framing it as like we're doing a different strategy to be like more efficient is really helpful. I'm curious, especially because you have like a nutrition background. Have you like dealt with like patients that deal with things like PCOS or like any other like hormonal imbalance, and how does that change your approach when you're working with patients like
that? For rehab, for pregnancy, or just in general?
In general, we can go there first. Yeah.
Yeah. It depends on what they're coming to me for. If they're coming to me specifically for PCOS stuff, then yeah, we're going to look more nutritional. I'm going to look at anti-inflammatory stuff. We might do some lab testing. I'll be honest, in more recent years, I have a couple of really good integrative, for lack of a better term, integrative docs, chiropractic physicians who really take on more of that stuff. So if it's a more complicated case nowadays, I have a couple of colleagues that I refer to, and I let them take those harder cases. PCOS might be an example of that, because that can be kind of in-depth. I mean, if it's generalized inflammation, perimenopause, like I certainly will work through some of the nutritional things, whether it's just fish oils and magnesium and a good multivitamin, and looking at any depletions that the medications that they're on might have, and addressing those things first. That's kind of my approach. It depends on how patients come to me. A lot of patients come to me directly for musculoskeletal things, and then some patients come directly for that nutritional side too. So it depends on what their expectation is walking in the door. Certainly if there is something systemic that I feel like is contributing to their musculoskeletal complaint, I'll mention and say, hey, I know you're here for your low back pain, but you also mentioned you have constipation, or you also mentioned you have skin issues. Like, here's some things we can look at, whether it's stool testing or just a good probiotic, or reviewing the supplements or things that they're already taking and trying to switch those out for something better a lot of times. It just depends on how they're walking into my office, but probably 90% of my practice nowadays is people walking in with musculoskeletal complaints. Not that we don't end up on nutrition things down the road, but that's more of what I'm doing nowadays.
Do you find that people, let's say they like had a history of PCOS, that their pregnancy like ends up being a little bit different than like your typical patient that may walk in through the door?
I don't know that I can say that I see. I can't think of anybody offhand that's been a real forefront of why they're coming in. So I don't really have an example that I can think of with that. So
Yeah, no, that's fair. Um, you had mentioned earlier about talking about like DNS and the and using different strategies when it comes to like breathing and stuff like that. Could you explain to the audience just like what is DNS and why is
Yep.
that important to you in your practice?
Yeah, so dynamic neuromuscular stabilization is the way I explain it to patients is that we know that as babies develop in their movement patterns, assuming the baby is intact neurologically, assuming that there's some sort of motivator, like they want to get to mom or they want to get to the dog or their toy, like babies will develop their movement patterns in a predictable way. And so there's these particular positions that are sort of milestones of that movement development, and the pressure points of like the elbow being on the ground or the hip being on the ground, that helps to stimulate both patterns of stability and mobility. And so we think those are somewhat hardwired, because whether you live here or you live across the ocean, like it doesn't matter your language, babies still, they roll over and then they start to push up and then they, do baby plank and then they start to cry. Like it's not that different culture, across
Yeah,
cultures.
yeah.
So we think this is somewhat hardwired. And so from a rehab perspective, we found that we can use those same positions, those developmental positions, because the brain recognizes them and says, oh, I know how to do this. I've done this before. And we can start to use those patterns to create strength and to create stability in areas that might be weak. So I've got the big posters on the wall with the little baby, the little baby and then the adult doing it, and talk about like, here's what we're going to do. This is what it's going to look like, and then kind of go into the rehab. Or even like in an exercise, I might say, like a sideline exercise, I might say, okay, we're going to do a roll, but what I want you to picture is if you kept going, you're going to end up on your hands and knees. And they're like, oh, okay, now I see where I'm going. So they can kind of picture the move. I said, we're just going to stop halfway though. So like a side bridge or a rolling pattern. So that's kind of how I explain it to them. And the benefit is, again, because those things are hardwired, like you can calm down a lot of hypertonicity. I was just working on somebody with a shoulder issue last week. I've been doing some other stuff and I'm like, sometimes I get distracted and I forget to put them in a DNS position, and I come back to it and I'm like, I could have saved myself a couple of weeks of care here, but we're here now. Getting them in like the prone position where they're supporting on their elbows, like if you can get them in the right position and start to get some breathing going, it's amazing how it calms down some of the hypertonicity around it without me having to go in and do a bunch of stripping or Graston or ART, because the brain then realizes, oh, I have these other muscles helping me now to create stability. I don't have to have this one locked down so hard. So I end up, sometimes I'll do one of those positions and then I'll go back and say, okay, now I'll be nice to you and I'll do some soft tissue. And I'm like, well, there's not a lot left for me to do because your body just took care of it. So it's fun. And sometimes it just amazes me. Like, again, when you go back and recheck what was there before and you're like, dang, that worked.
Yeah.
It's
I know.
even I get excited about it. So
One of my favorite things in clinic have been like, what DNS position can I put you in so I don't have to like go after that annoying trigger point in your trap, because I really don't want to work on it.
Yeah. So true. So true. Yep.
Yeah, my one friend in clinic, she has I think she called her trigger point, she named it like Bertha or something. And I was like, why are we doing this? Just do a DNS position and put it away. Yeah.
Yeah, exactly. Yeah, and I had one, actually the same patient with the shoulder stuff. I treated him for something in his hip. I don't know, 6 months ago or so. And I was like, oh, remember that thing we did for your hip? Well, now we're going to do the same thing, but this time it's for your shoulder. So yeah, where I was doing the sideline rolling where you restrict or resist the rolling of the pelvis to help release the adductors. Yeah, and then we just went up and did it in his shoulder to release like posterior deltoid tightness. So it worked. It was fun to be able to be like, okay, the same thing we did, we're gonna just do it in a different way now, or different emphasis. Yeah. So
no, I love how like versatile DNS is, and like how depending on how you cue it is like and what you're focusing on, you can still use the same thing but like in a different way.
Yeah, I'll say for me, it's been really hard because it's taken me a really long time to feel comfortable with what to pick because there's just so many possibilities of how you can do it. So kind of narrowing it down to a couple like tried and true, like the supine 90-90. I use the sideline rolling pattern for hip or shoulder quite a bit. The prone 3-month-old position I use. Like picking a couple. Um, for certain things and then kind of honing in on that and getting good at those things before you add on like the hanging position, or for those who know what the heck we're talking about at the moment. But like it's kind of a rabbit hole. It can be kind of a rabbit hole, but I think taking little pieces of it and really trying to say, okay, can I use this and this? Can I use what different things can I use in different scenarios, and then kind of narrowing it down so it gets easier to pick which one is the best, to start with. And then if, again, it's another example of like, if the patient doesn't respond to it right away, it's like, well, what other position could I use? What's a different strategy? And just kind of working with where they're at.
No, I love that, because I know in clinic right now, it's like when I'm picking like a DNS position, I'm like, well, I could do this one, but I also could do that one. But then if you narrow it down to like the few couple just to focus on, then you get better at the cueing and you understand the position more.
Yes. Yeah. And that's what I feel like I've had to do for myself, because it felt like such a big, it felt so huge to me. And so for me to kind of narrow it down and be like, I'm going to get good at this position and I'm going to get good at this position. And like you said, cueing, it's made it a little bit easier over time for me.
For sure. Going back to like more the baby stuff, to where like some people can understand what we're going on about.
Sure.
Why are these early movements so important for the baby?
Yeah, because when I have a parent in with their baby, I take them in and show them, we look at the posters again, and I say, listen, you don't need to practice walking. Like, in each and every one of these positions, the body's learning something, and they're getting stronger at something. So when they go from their side and push up onto their hip and come into a crawl position, there's a ton of hip stability and strength that they have to do to go from like lying on their side, like let's say call it lounging on their side with their hand down or their elbow down, to being able to press all the way up into a hands and knees position. Like, that's a lot of coordination and strength around that hip. And every time they do that, every repetition, when the baby's crawling around on the floor and, chasing the dog and splashing in the dog water — that was my house. It's like I couldn't keep the kids out of the dog food. That's a repetition. That's an exercise for them. And so then when it comes time that they go, I think what's up there, I think I want to pull myself up to standing, they've already had a bazillion repetitions of shifting over that hip to find the stability and find the coordination around the hip. So then they're ready to stand up. So that's where I talk a lot with patients about, like, take away the mommy competitions of, well, my baby walked at 9 months. It's like, they're not supposed to walk at 9 months. They probably missed some things, So just setting the expectation. It's good to set the expectation of them with, like, it's okay that they don't walk until somewhere between 12 to 15 months. That's where it's normal. They're still gaining a ton from crawling, from shifting, from rolling around. Like, there's something to be learned and gained at each and every one of these positions. And if you skip that, or if they only roll one way and not the other, if they always step up with the right foot and never the left, they're going to have less stability on that other side that they didn't use. And so we want to give them as much opportunity at those lower level positions before going to those more upright positions. So it's one of the things that when I get a teenage athlete in here and with a hip injury, let's say, or even a knee injury, I'll ask them, do you know if you crawled? And usually they're like, I'm like, go home and ask your parents if you crawled, or if you've crawled funny. Did you do a boot scoot, or did you only army crawl? Or and oftentimes they'll come back and say, oh yeah, I did some sort of a weird thing, she said, where I only used one leg. It's like, oh, okay. It was the right leg you used because the left leg's the one that's not
So
great now.
crazy. Yeah.
And so, yeah. And so then we'll go back and be like, all right, well, I'm going to put you in this baby position of pressing up on your left hip to get up to hands and knees instead of your right hip and re-strengthen that. So, but I use that in the peds too. People are asking, are you adjusting babies? Yes, I adjust babies. It doesn't look anything like adjusting an adult, but I do adjust babies. It's more of a mobilization or pressure on, pressure off. There's not a lot of like thrusting until after age 8 or so. To some extent, depends on the area, but I will certainly in those kids younger than 2, we throw toys on the floor and I hand them things and watch how they move. I mean, that's my assessment. I throw a big blanket on the floor or a towel on the floor, and me and parents get on the floor and we play with toys. And I just get to watch them move. I lay them on their back. I try to get them to roll one way, lay them down again, try to get them to roll the other way. And if they're doing something asymmetrical, then I'm going to start to put them in a position that stimulates them to use that other side. And then send the parents home with it. And that's their homework. Go play with your kid on the floor, but make sure they're reaching to the left to get to it, instead of just the right. So, yeah.
No, I was curious, like when you have a baby, let's say that they are only using that like right leg to like get up and like stand up. How are you basically just forcing them to then start using their left leg, or like what does that look like?
If you take the DNS pediatrics course, there's some holds where we hold them across our chest and then take their foot and put it on the table. So I make my microphone fall over. We put it on the table and kind of force them to step up with that leg, and we can get them to do that a couple repetitions. And then sometimes you put them back down on the floor, and then all of a sudden they crawl around and they step up with that foot, and you're like, oh, that was easy. Sometimes it's just showing the brain like, oh, don't forget you've got this side over here too, and you can use it. Input into the brain always helps the brain control, have more muscular control coming out. So if I can give them that sensory stimulation of here's the left foot stable on the ground or table with the knee over the foot with the hip in line with the knee, and get them to press up with that foot, like feel the engagement and press up with the foot, then they go back and start using it. It's really cool.
That's awesome how it just like clicks in and is like, oh, I feel stable here. I can actually use this leg. Yeah. Yeah, so one of my friends, he brought his like baby in the clinic, and it was really interesting because I hadn't been able to like mess with a baby, like
I understand.
You get to like work with the baby, I guess is the better term to use.
Yes, that's probably a better term to use.
Yeah. And his baby was pretty big. He was 9 months. But
it's a great age to mess around with.
Yeah. And he was super chill too. Like he was just, he had his pacifier in his mouth and he was like, I'm just chilling here. Like barely cried. And here you have like 4 interns just surrounding this baby being like, what's going on? And we had noticed like his erectors almost felt really tight, and he was like like it almost looked like he was in so much in belly, like on his belly the entire time. But we had noticed that like he always wanted to roll to the right versus the left. And so we had thought like maybe like, okay, maybe we need to like keep rolling him to the left. But he would just get like super fussy the entire time. I know you haven't done like a full assessment on this baby, but like with something like that, would you say we just need to keep rolling him to the left? Or like even one of us were like, maybe there's like a PI when it comes to like something going on with his sacrum that's preventing him to roll?
I certainly will palpate SI joints. I'll palpate through the thoracic spine even. Like a lot of time, if they're real hypertonic through there, I might even go back to just a supine 90-90 position. And you can do like a gentle stabilization over the rib cage, like I hate to say like pulling, but like gently tractioning the rib cage down towards the pelvis, and then just holding the knees up at 90 degrees. So now you've got that parallel position between the diaphragm and the pelvis, and just letting them hang out there. And then if it's one particular direction, I don't roll them, but I'll put them on their side in the position and have somebody playing with a toy out in front of them. So, if it's they're not rolling to the left, I can't remember which side you said, left elbow's down, And then the right leg, start to kind of maybe mobilize the right leg over the top, or you can push on the pelvis and the scapula and just kind of roll them forward, roll them back, roll them forward, roll them back. So again, there's just like we would do with an adult in that side leg position that we were just talking about, getting them to load the shoulder and the hip starts that sensory input into the brain. The brain goes, oh, I feel that. And then the brain can better create stability around those joints. So sometimes it's just putting them in the position, letting them kick around, holding a toy in front of them. Giving them the opportunity to be there, but not necessarily rolling them all the way over. Just let them hang out there, because the sensory input is going to be enough at some point that they're going to want to do it. And they're going to want to reach for the toy and get there at some point. The other thing I'll do with those kids is talk about which way they lay in the crib, or somewhere where they're at on a regular basis. You know, if their crib is on one side of the room and they're always laid down with their head to, let's say, the far end, then when they wake up and they're looking for the parent, they're always going to roll that same direction, you know, to reach for the door or to get to the door or to get to the side to pull themselves up. So we'll talk about, like, lay them with their head the other direction, so that then when they wake up, they've got to roll the other way, or they're at least looking the other way to see who's coming for them. It could be just playing in the living room where the dog or the older siblings or whoever, and they're always same thing, one direction. Can we switch it so their visual stimulus is on the other side of the room, so they're stimulated to go that other way? So I start with the input more than I do the can I roll them, because we know that the input should stimulate the movement.
So it's like you just basically need to change the baby's environment, and I love that, like, even the parent can do that. They
Totally.
have the opportunity to, like, change the way that the baby gets to move.
Every single thing that I'm doing in the office with DNS or with mobilization or stability stuff, I'm always sending the parents home with at least a couple things to do. And with the understanding that, like, I get that life's busy, but every time you change your diaper, I need you to do 3 repetitions of this. You know, I attach it to something like that, because me doing it, even if I'm seeing them 2-3 times a week, like, me doing that 3 times a week is not going to be anywhere near the input they need compared to 4 or 5 times a day with a parent at home. You know, they need that repetition. And oftentimes if they're doing that at home, they progress really quickly, in my experience. Again, assuming they're neurologically intact and there aren't some, you know, bigger things going on.
Yeah, for sure. I'm curious, like, with some babies being more relaxed versus others, what do you find that, like, babies tend to struggle with when it comes to, like, feeding and sleeping, and what are those things that you're looking for to help change that?
Feeding and sleeping in particular, like, I will refer, like, I definitely will refer to lactation consultants. That is one where I really want it's called IBCLC, International Board Certified Lactation Consultants, IBCLC. So I really will seek out, you talk about non-negotiables, like, I want somebody who's got those credentials behind them and extra training. Like the one that I referred to for many, many years, she isn't around as much anymore. I think she's further east, but she's both she was a nurse, got her master's in nursing, and then got her IBCLC. And like having somebody guide you through that, like, you know, back in the day, it was aunties and grandmas and all of that. And we just don't have quite as much of that community as we used to. And in that intensity, it's just culture has changed. So, and you think, oh, it's just natural. It's breastfeeding. You hook them up and you go. And I think whenever I can get to patients when they're still pregnant and not already struggling with breastfeeding, you know, trying to get them set up with somebody before the baby's born, because it's a learned process both for mom and for baby. You know, the positioning and how to latch and how to hold the baby and to get a good latch. Like, there's technique to it. And if you can get that down, it does help quite a bit. Now, yes, there are times when, like, the baby itself is really tense and they might have trouble just even opening the jaw, or they're so fussy and so upset that it's really hard for them to relax enough to get a good latch. Those are the babies that I'll do some like cranial sacral work on. But some of it too is making sure that the mom is in a good state, because the more tense, it's such a circular thing, because feeding troubles are so hard when they're little, because it's like that's your only job for a certain amount of time, and to some extent is like to feed them and change their diapers and get them to sleep. And to have struggles with that can be really stressful on the mom. And when they're tense, then the baby's going to be more tense. So, treating the mom as well, trying to help get them to relax, and then also treating the baby to try to get some calming in their nervous system, I think is huge when it comes to that. So, but it's got to be a team effort. And again, from a technique perspective, like having an IBCLC to help with latch and help with breastfeeding itself is huge. But yeah, the tension side of it is, it's typically craniosacral stuff that helps to calm that down pretty quickly.
Yeah. What would you tell that mom right now that's like struggling with like a really tense baby, or a baby who's like struggling with feeding? What would you tell them right now?
Get help.
Yeah.
I mean, honestly, like I think we're in a society so much that we're such independent islands, and we're not meant to do that. That wasn't how society was years and years ago. You had people to support you through this, who knew how to do this, who knew how to help you. And I think this is one of those scenarios that if you're struggling with feeding or struggling with sleep's another story, but definitely the tension, getting help from a lactation consultant or a chiropractor. Like, you got to go get hands-on. Sometimes you can't do it yourself.
Yeah, I feel like in a world sometimes of like the whole like Supergirl girl boss sort of thing, and then now with like YouTube and like AI and stuff, people think they can do all these things on their own, and it makes them more powerful for that. And it's like, no, like asking for help can sometimes be the most like strongest thing you could ever do.
Absolutely.
Yeah. When it comes to like the parent, maybe they're like observing the baby a lot, and a lot of things are going on. They're trying to like feed the baby, they're trying to like get some sleep because they don't have any sleep at all. What are some things that you typically tell parents that they need to be aware of and pay more attention to when it comes to their baby?
I think looking for those asymmetries. That's like as they're growing, like not the first month or so, but like as they're growing and developing, like watching for asymmetries, watching for weird things that don't look right, and then coming and get checked. I try to get them to come in once a month or so in the first year or two, to make sure that we're seeing good development, that we're seeing good motor skills. Otherwise, if they, for whatever reason, don't want to do that, I'll usually say bring them at the next milestone. When they start pressing up, when they start crawling, when they start walking, like I want to see them at those times. So asymmetries is a big one. Another red flag, obviously, and this would be, the pediatricians will tell you this too, is a loss of skill that had already, or a loss of a milestone. Like you hit a milestone and then they lost it. Like that's kind of a red flag that needs to be assessed, and we need to figure out why. I try to teach just things like, and the pediatricians will tell you this too, like the first 90 days, it's a fever over 100.4. And after 90 days, it's 104. So 100.4 for the neonates, and then 104 after that period. So, those are things that's like, okay, this is when you need to get help. I think if you're going to treat peds in your practice, there's a great paper on, I forget what the right word for it is. It's not standards of care, but consensus over how to treat pediatrics. What are red flags? What are yellow flags? Clinical Compass has it. I don't know if you guys are familiar with Clinical Compass or I think there's a student access to Clinical Compass, but they have a standard of care for pregnancy. They have it for pediatrics. And it's basically, they surveyed chiropractors and all across the profession from different approaches and said, what can we agree upon what can we agree upon in terms of like this patient should be in our office or this patient needs to go get additional help. And knowing those red flags and yellow flags so that you can recognize them in a patient who might be in your office and being able to send them off. I think that's huge. Not necessarily what I'm telling the parent, but knowing as a physician what I need to be on the lookout for and to get them back to their pediatrician or family practice or whoever's taking care of them. Like, I think that's really important.
Yeah. Knowing if something needs to be in your office or doesn't need to be in your office is as important. Yeah.
Yeah. Oh, huge. Yeah.
Yeah. You had mentioned, I meant to ask you this, but I completely blanked. The cranial sacral. Could you go into depth on like what that is, what that looks like?
Yeah. There's a woman named Lori Hendrickson, who's a craniosacral therapist. She teaches some pretty good courses. I took a course with her a little last year, maybe a year or two ago. It's very, very gentle. I mean, it's like really light touches. And it's people who are, and again, I'm not an expert in craniosacral. I do some of it, but it's not my official expertise. I'm not a certified craniosacral therapist other than the pediatric course with Lori. It's very gentle. I think of it as, again, that parasympathetic stimulation, that if we've got all this sympathetic, like fight or flight, it's a way to tap into the parasympathetic. So it's very gentle movements at different points on the cranium to help the movement of the cranial bones. Yeah, and the effects are mainly parasympathetic.
Okay. Now, is this something, because I know some people talk about it as like using it with adults, and then some people say use it for just babies. I was curious what your stance on that is.
You can do it on both. I am impatient and tend not to use it on adults. I have other colleagues who do, so I think it's partly my own preference. I tend not to use it so much on adults. I use it more on the babies. But I like I said, I have other colleagues who use both. So I don't want to discount it because I know others who've been successful with that. I just tend not to myself.
No, that's fair. Yeah, because I was always curious. Like I was in gross anatomy lab, and it's like the brain is fused, like the skull.
They are, but they still feel like there's some slight movements. Like even though the sutures are fused, there's still some slight movements that occur. So if you've had a head injury, I mean, the whole thing came about as like this guy put his head in a vice and saw what symptoms he created with it. So it's a little archaic, but at the same time, like
guys
I don't want to
discount.
I don't want to discount it completely because I know that there are certainly people who are like fully gone down the up ledger, that have positive effects on their patients. So I just don't use as much of it in adults to be able to say one way or another, like yes or no. But there is a little bit of movement even in the fused cranial joints. So
that's fair. Yeah, because I was almost thinking
that's the way I look at it, at least. Like they're fused, but there's still a little bit of wiggle.
Okay. Yeah, because I almost was thinking like maybe someone had like a super tense like temporalis muscle and maybe we were just working on that, but I need to do my own more research on cranial sacral because I haven't done a ton. So
yeah, and again, I'm the same way. Like I tend to use it more on babies than the adults, but like I'll do like a suboccipital release. But I feel like I'm affecting fascia. I have a neurologic input in terms of the sensory input. I was telling a patient today too she was asking about infrared saunas and I was kind of talking through it. I was like, hey, if it makes you sit quietly and like meditate for 20 minutes in a somewhat dark room, like there's benefit to that. So, I'm not gonna discount that, even though infrared oftentimes just gets to the surface of the skin in a sauna, but it's the same kind of thing. Like if it forces somebody to lay quietly on a table, and that's the hard thing sometimes to separate between some of these treatments is how much of it is, I hate to say, placebo effect, but there's a benefit in making somebody lay quietly in a dark room.
That's fair.
And so I don't discount that, and I don't say, Well, that's nothing because it still is. But do we have scientific proof to show one or the other? I don't know. It's not my specialty, so I don't want to say one.
No, that's fair. Yeah, definitely. I think it's that whole thing of like, there may be some benefit, there may not, and if it's working for that specific patient, then great. If
Yeah,
it's not working for another one, then it's like, okay, we need to find something else, and that's why you need to have multiple tools in your tool belt.
correct. Yeah.
Yeah. When it comes to postpartum, I feel like this is something that a lot of people like skip over and don't really like to talk about. And then, of course, I wait till the very end and we're an hour in,
It's okay. I
and
know,
I
and I
do the
can
same
talk
thing.
a lot about it.
Yeah,
Yeah.
I was curious, like, when it comes to like the baby's arrived, there's like all this pressure that the mom feels of like needing to quote bounce back.
Yeah.
What would you tell that mom that like feels like I need to bounce back, but like maybe there's like some physiological things we need to be like focused on right now, and they're just like ready to go gun ho out the door when it comes to like dieting
Yeah.
or exercise? Yeah.
I think there's a lot of factors. I try to explain to people that like if you're breastfeeding, you actually need more calories breastfeeding than you did when you were pregnant.
Mm.
So making sure that your nutrition is up and making sure that you're getting enough calories and getting enough water or liquids, like that's part of the way that you're going to keep your milk supply up. If you put yourself under too much stress, whether that's caloric restriction, whether that's excessive exercise, your body's not going to produce milk as well. And so then you have to decide what you want to do with that. Are you going to stop breastfeeding early? Are you going to switch to formula? Like that's a choice. You can do that. We have those things available. And so I think it's kind of, well, yeah. So keeping up nutrition, keeping up hydration is a big one, but also recognizing that from a mental perspective, like being able to move and being able to start to work out again can be really important for people. I think, like we talked about in the beginning, like knowing your body and trying to listen to your body and make sure that, if you're getting signals that you're doing too much, that you back off and just give a little more time. A big one is the postpartum bleeding. After you have a baby, your uterus has to recover and heal. And so, that can go on for 4 to 6 weeks even. It's a long time. It should be done though by 6 weeks. So if you're working out and some women will talk about like after a hard workout, they'll get an increase in that. Well, that tells me that it's probably a little too much too soon for your body. If you're real sore afterwards, like you really you can't just jump right back into what you did. I don't want you to do nothing. But at the same time, honor the fact that you still got some healing happening and work through that. But I think you can go back out to light workouts when it feels comfortable to you. And I used to give a strict like, okay, you should wait 4 to 6 weeks before you really start doing this. You should really just bond with the baby. And yeah, the bonding with the baby and getting established with breastfeeding and getting comfortable with there's not a lot of comfort in those first few, but getting used to taking care of this other being and feeling what life feels like that's a lot of emotional strain. And so it depends. Does exercise feel like relief? Cool, then exercise. Does exercise feel like more pressure? Well, then don't. So knowing yourself and how you feel about it, knowing what the load of either exercising or not exercising feels like on you, like I think that's more important than a strict like X number of weeks. Now if you've had a C-section, that's a different story. You do have some limitations in terms of lifting and things like that for the first 6 to 8 weeks maybe, but it's a surgery. You would with any other surgery. You'd have a limited period of time, but not necessarily with birth. I think you really kind of gotta feel your way through it. And like I said, I used to give more hard answers, but I feel like there's more leeway we can take now than what we used to think.
Yeah, for sure. It's like you said, going back to like, what does your body feel? What are the signals that it's giving you?
Yeah.
And like being able to slow down enough to like actually listen to those signals. When I find it really interesting that you're like, I used to have hard and fast rules, because like especially as a student, like I'm looking for those, like, what are those hard and fast rules? But then it's like, again, what is the patient coming in with? And then I also think it depends on like, what did their exercise look like before going into pregnancy? Do you find that there's
Exactly.
major differences when you have a patient who did
Oh,
versus
yeah.
didn't?
Oh, for sure. Yeah. If you were somebody who was working out a ton and lifting and just for a long period of time, if that was just your lifestyle before, then you're probably going to feel better going back to exercise quicker than somebody who didn't do as much or did maybe just yoga and walking. Like, but even that, like that can be really good. And maybe you do a 20-minute walk instead of an hour walk, and you do a flat course instead of a hilly course. Like, but again, I look at the emotional component of that too, and how many people need that kind of emotional release of exercise, and not blocking that, because that's going to be part of the way they can start to deal with the stress of breastfeeding or the stress of not having as much sleep. But if they can get out for a walk or get out for a workout and then come back and be calmer when they get back with the baby, well, maybe then breastfeeding goes better because they're in a better mental state as a result of having gone back to exercise when they felt like it. So, yeah, I've just tried to help people, like, how do you feel? What do you want to try? Like, what about this? Have you thought, well, maybe you don't feel like doing a full, hour workout. What if you did just, 20 minutes, and kind of just reframing it for them, but giving them space to kind of try it out.
Yeah. Everything doesn't have to look the exact same as before birth to like right after birth. And I love how you were just like, it could be 20 minutes. It doesn't have to be the strict hour workout that you're used to.
Yep. Yeah.
Yeah. And I love the part where you had talked about the emotional component. Like, I don't feel like enough people think about that, like how little something like a 20-minute workout, if that's something that fills up your cup, or maybe a 20-minute meditation, if that's more your vibe, like
Totally.
that could help you be more aware and present with the baby that you have in front of you and have a better connection.
Yeah, exactly.
Yeah. Is when, let's say, like, a patient does want to get back into exercise, is there anything that you have them focus on beforehand before going back into exercising, or is it more just like, hey, whatever, like, makes you feel good?
Yeah, it depends on the scenario. I mean, if they had any sort of like tearing, if they had to have stitches or episiotomy, like I might try to get them to wait just a little bit longer because those tissues kind of need at least a couple weeks to kind of heal up. C-section is a different story, but assuming those things are not a factor, something to focus on. I think honestly, in the beginning, whatever feels good. Breathing, I think if anything, it's breathing. Can you breathe in your belly? Try not to suck your belly in the beginning, but try to breathe into that space that's now back that you didn't have for a while, that was encroached upon by a certain someone. So just that, like, really trying to breathe in the belly, breathe in the low back. I think that's part of it. We joke that kind of let your pelvic floor be your guide. If you're doing something and you're still struggling with stress incontinence, well, you've probably got to back off just a little bit of the intensity. So let your pelvic floor be your guide. If you're peeing your pants, you're probably going too hard on whatever the exercise is. So, I mean, we laugh, but it really does take a while for the body to rebound. And they've shown that most of the time, if you have stress incontinence initially after birth, like if you keep moving and rehabbing, that typically goes away after a couple months. If not, then you should probably see a pelvic. That would be the other thing, is see a pelvic floor therapist. Have an assessment. Not right away, but within a month or two, probably. Again, it depends on the scenario exactly. No episiotomy, healing. Like, I think everybody should have an assessment with a pelvic floor therapist postpartum. I think if we gave women the rehab resources, I think we wouldn't have so much low back pain later on. And issues with pelvic floor stuff later on too, if we tried to address those things earlier, as a norm.
Some of it comes from the fact that no one wants to recognize that area as being an area. Like, everyone's like, I don't want to touch that. Like,
yeah, exactly.
To where the awareness isn't there, but it's slowly growing, I feel like.
It is. Yeah, I think so. Yeah.
For the patients that like are scared, I know there's a lot of information about like diastasis recti, where it's like dealing with that. Do I have it? Do I not? Like, is this separation a good thing or a bad thing? What does that look like when you're talking to a patient who's worried about that?
Yeah, I will check them. When they come into my office, I'll see, how much is there, how long is it, how wide is it. I'll check it, but then also talk about like your body has the ability to heal this. Like some of this is just normal as part of pregnancy. Like it's made to stretch. Some of this will close back up. Let's give it some time, continue breathing. We're going to teach you some stability abdominal work. Over time, I might do some like hands-on, just same thing, like trying to get in on the attachment points or working along the linea alba to stimulate that neuro input to help the brain kind of find those muscles again and better control them. So I will work on it certainly, but then kind of just slowing down and saying, hey, just give your body a chance. Let's do some rehab. And we do see too that even if it doesn't quote unquote close up completely, if we teach the ability to stabilize, it doesn't have to be completely closed to be functional. Yeah, I mean that's been kind of my take on it. Yeah. And they're showing too now, even if you do get a little bit of tenting, it's okay to work those muscles. Like we don't want a ton, but like it's okay to get some tenting when you're working it, especially in the beginning. And because you're trying to create some strength and stability in that area, we have to work the muscle at some point. Otherwise, we just continue to atrophy. So.
Yeah. The importance all goes back to building strength and rehab. I love it. I love it.
Yes.
Just get out and move. Yeah. Find something that's enjoyable and move. Yeah.
Yeah. Mm-hmm. Mm-hmm.
Well, I have enjoyed having you on the podcast. I feel like I'm going to have a part 2 with you because there was so much more. I feel like we could go down rabbit holes for forever, and you're such a joy to talk to. But if, let's say, someone wanted to find you, maybe you're in Chicago, right?
I'm in the far western suburbs. So yes, I am in where the suburbs meet the cornfields is where I tell people. I'm in Elburn, Illinois. So my practice is called Trillium Health and Wellness. My website is trilliumchiro.com. If you're in my area, I would be more than happy to work on you. I'm on Instagram. My teaching stuff is Dr. Ericka Mennerick, so just DR and then my name, Dr. Ericka Mennerick. My practice is trilliumchiro.elburn. Those are my Instagram pages. Those are probably the best places to find me. And yeah.
Perfect. Awesome. Well, thank you again for being on the podcast.
Yeah, thanks for having me on. This is a lot of fun.
Thank you so much for listening to this episode of Becca Babbles podcast. If you enjoyed this episode, the best thing that you can do is leave a 5-star rating and review on Apple Podcasts, Spotify, or any other listening platform of your choosing. If you want to learn more about me, you can do that by following me on Instagram at Becca and Wellness, or by checking out my blog, freebies, offers, and newsletter on my website at beccaandwellness.com. If you want to share the love of the podcast, you can do that by taking a screenshot and sharing it on social media and tagging me and the podcast at Becca and Wellness and using the hashtag Becca Babbles Podcast. I hope you have a great rest of your day, and I can't wait to babble with you next time.